pictures speak a lot of words. Do you agree? We will be talking next about molecular imaging at Mayo Clinic, Florida, evolution in personalized medicine, how we can take pictures in medicine to the next level. We have Dr. Manoj Jain. He's the chair of Nuclear Medicine, Department of Radiology, Mayo Clinic, and there's actually a building soon for our cyclotron at Mayo Clinic, Florida. Welcome, Dr. Jain.
Good morning. It was a great talk by Dr. Rizzo, and I'm following him. I think it was a big lesson for me. And it was a teaching for me because we are radiologists, and we usually sit on our chair in front of computers for hours and hours looking at your images. And I think that was a plan by Dr. Tan so that I get the lesson from it. And first, I would like to thank each one of you to come to this symposium. And this is my first time here. And I will be talking about imaging. But before that, what I want to ask you, how many people in the room know what a PET scan is? Have you heard about a PET scan? I'm talking about positron emission tomography and not a scanning of our beloved PET. So I did see a few hands that came up. So that is one of the things that we use to image people, and that has changed imaging for oncology or cancer significantly and has become an invaluable tool. Cancer cells, I know we have a lot of oncologists around here, but cancer cells, to my understanding, are cells which just keep dividing very fast and in an uncontrolled fashion. They can behave like normal cells and they're still multiplying, or they can become undifferentiated, what we call, or change their morphology or their way they look, and then divide. So these two differences make those cells different. Cancer cells love glucose. They just want to grab as much glucose as they can. So they have to multiply, so they need DNAs, they need proteins, and they need a lot of glucose. And that is what has become one of the major tracers. You can call it a tracer, you can call it a probe. There are multiple interchangeable words, agents or radionuclides, that are used for these tracers. How many of you think a radiologist need to go to a medical school to be a radiologist? Okay, I do see a few hands. Because we don't see patients most of the time. We are hiding in a dark room and reading our studies and trying to make the best of your images. At Mayo Clinic, the most important thing is we do have a multidisciplinary approach. All the cases, all the imaging that is done are discussed with multiple physicians being in a room in tumor conferences, and that is how the management of the patients is discussed and handled. So today I will be talking mainly about molecular imaging that is used in radiology and in the Department of Nuclear Medicine. And PET imaging will be the major discussion. So some of my colleagues who helped me put this presentation together. And I will start with the patient story. And the reason is it explains how these cells and the molecules that we send into your blood, the radioactive molecules work. So this patient, 70-year-old, carcinoid tumor is a kind of neuroendocrine tumor, which are not very common, but there are neuroendocrine cells normally in your body, and they start growing, and that is what a carcinoid tumor does. So the patient was on therapy for about 5 to 7 years, stopped the treatment, started having symptoms again, went outside and got a PET scan. That is the most common thing that we do with glucose. But that did not show much of the disease. And I'll tell you why that happened. And then there is a recently approved radiotracer or an agent that we inject in the blood, a small amount of radioactivity. That goes into your blood and seeks certain cells. So this, what it does is, these are the images of the patient. So on your left-hand side is a sugar-based radioactive substance, which is like glucose. It goes into your blood, it will go into the areas where you need glucose, or like the brain. You see this hot area? This is the brain. Brain wants lots of glucose, so it's a normal uptake in the brain. Same thing is, your intestines are moving, so the sugar goes into that area. And so, if the tumor is rapidly growing, they will take up. But these tumors, in their early stages, have normal cell appearance, they're well differentiated. So they do not take up, but they have specific receptors, or you can say sensors on the surface of the cell. Those sensors take certain other agents, and that is what we need to work on to make it more personalized to each type of cancer. And that is where most of the work is going on as far as research is. So this is the agent that was approved, and you see certain areas. These are all normal areas of cell uptake, but you see something here? So when you see this scan, which is the glucose scan, you don't see anything abnormal, and then you see the abnormality on this scan. So these have specific receptors called somatostatin receptors, and that's why they take up. But the important thing is most of the imaging, a lot of imaging that we do in radiology is anatomical. We don't get to know the function. So that is where PET imaging is important, because it tells you both about the anatomy as well as the functional aspect of the disease. So the CT scan does not show anything. So before there is an abnormality on the bone seen on a CT scan, you can see that there are already abnormal cells in the patient. And that is how you find the disease, and that is how we treat the disease. We usually don't get to meet most of the patients who come to the hospital, but we definitely see you. We see you in the form of images. And this is how we see you. At times, this is another PET scan, and sometimes we can even make you move. So these are some of the molecular imaging techniques. Most of them are still in the preclinical stages where their experiments are going on, and those are more of optical as well as photoacoustics. The rest are being used in practice in some way or the other, some more than the others. And PET imaging has become the most important tool for molecular imaging. So this is how a PET scanner looks like. It is a donut hole. The patient goes in and gets scanned. So most of our scanners look like that. So when we inject a small amount of radioactivity into the patient's arm, the amount of activity is usually a fraction of a size of a grain of salt. That is the amount of activity that is being injected into the patient. These are detectors. So the signal comes from inside the patient outside, and that signal is captured by the detectors around it. And Those detectors then goes through some electronic systems, and finally we get an image. And this is what the image looks like. It is safe, it is non-invasive, and it gives a lot of information, both about the anatomy as well as the function. Patient preparation is very important, because if we are doing a study with something like glucose, we don't want glucose to be already in there. Otherwise, because these radioactive substances, they go through the glucose metabolism pathway. So they go through, so it just is acting like a sugar. So it goes into the cell and it stays there. From there, it gives you a signal. And the signal that comes out is captured by the PET scanner. So currently, we are using it in oncology. Cardiology, we are not currently using PET imaging, we are using SPECT imaging, which is a different form, but we will be using it for cardiology pretty soon. And then we are using it in neurology, especially in cases of dementia, epilepsy, and tumor recurrence. So a patient gets a CT scan, comes in, the first question is, gets a CT scan, they see a nodule. The question patient comes and asks is this cancer? Most of the times, we don't know till it is biopsied, but a non-invasive way of doing it is to get a PET scan. It does help in telling that its likelihood of being a cancer is higher or lower, or if there is any other disease surrounding it. Because if there is a spread of the tumor, then we don't know where it has gone, depending on the area the CT scan is done. The other thing is, smaller areas of spread may be considered normal based on the size. On the CT scan, because we do not have any functional knowledge about how that tissue is behaving. So this patient comes in, gets a PET CT scan, and you see this hot area, which corresponds to the nodule that we see on the CT scan. The other thing that we did not see on the CT scan is this smaller area, which is a lymph node, and if we go how we read CT scans and based on the size thing, this will be not called abnormal. But once a PET scan is done, we know that it is taking up glucose. Sugar is going there, and there are abnormal cells. The other important role is, has my cancer spread? Has it gone to other areas of the body? And this is a patient with breast cancer, and you can see, you hardly see the outline of the body. And the reason for that is, most of the glucose that was given, you can see it in the brain a little bit, but most of it is going to the tumor areas. All these things that are lighting up, except for the kidneys and for the urinary bladder. Why do we see it in the kidneys and urinary bladder? Because that is how it gets out of your system. The advantage of these PET agents is that they all have a much shorter half-life. That means they decay very fast. So like this radiotracer or agent will have a half-life. So if we give 10 millicuries, after 2 hours, it will be only 5 millicuries left. So every 2 hours, it will decay to half of what the value is. That's why they get out of the system faster, and also they are excreted out of the system. So on these images, you can see this was the breast nodule on the first one. And then the other question is my current treatment working? So in between these two scans, the patient got the treatment done. And on the second scan, you can see more activity in the brain, liver, and wherever these areas of hot activity was there, you don't see them anymore. So And these are the images when we do axial slicing. So an average, a PET CT scan, we go through, or we have about 1,500 images on one patient. So that is the number that we usually have on every patient, anywhere from, I would say, 1,300 to 3,000, depending on how much of the area of your body we have scanned. So you can see this activity in the liver. It is gone on the follow-up scan. This is the bone lesion. It is gone up on the follow-up scan. So the next question comes, how do we produce the tracers? The PET tracers are produced when an element is hit by a very high-speed proton, and that we can do using something called a cyclotron. So I will show you, we are in the process of building a PET radiochemistry lab to make newer agents that are going to help us both in research as well as in taking clinical care of our patients. So this is when this equipment was being, so it has to go, a crane is used to bring it into the building. And the weight of this equipment is around 44,000 pounds. And you see this thing? This is something that covers the whole of the building through which it is coming, and this is around 40,000 pounds. So, and the second part of that is all concrete. It's like 6 feet thickness of concrete. And this is the image of the lab that we are working on. So the cyclotron has been put in. This is where the cyclotron goes in. And these are 6 feet thick concrete walls on all sides. And the reason for that is we don't want the radioactivity to impact our public or the employees who are working there. This is the lab area where all the radiochemistry happens, and the rest is office space. So this is a cyclotron where the isotope production happens. This is something called a hot cell. What happens is your radioactive substance is built in the cyclotron, it comes into this, and it gets attached to a chemical molecule, like glucose. So it will get attached to a glucose, and that's how the agent is formed and goes into your blood. And then there are multiple systems for quality control to make it safe to be injected into a patient. They have to be sterile, they have to be safe, and that is why this facility, before it can be used, is inspected by the Food and Drug Administration. It is like a drug production facility. And then the doses are dispensed. So the next step, what we need to do, and we are working on it right now while our cyclotron is being built, is to get new tracers, new agents which can help in finding disease. So that will be to take it to the preclinical stage, doing experiments in small animals. And we are currently working on trying to get a micro-PET seeding. So what this cyclotron or a PET radiochemistry facility is going to do is to make tracers for clinical use, then it will make tracers for research. And then once those show that they are effective and can be used in humans, then we take it to the next level to be used in human beings. So these are some of the drugs that are FDA approved. And these are some of the ones that we plan to start when we start our cyclotron from the standpoint of research. Recently, the Food and Drug Administration approved these 2 radiotracers. I'll tell you, one is this. That was my first example that I showed you. And the other one is this for recurrent prostate cancer. And this is another tracer that has been approved for treatment, and I'll tell you how that works. So this is the first example that I showed you that it was not positive for glucose, but it was positive for this. Before starting this, I just wanted to tell you the glucose labeled tracer is used for most cancers. So that was the first approved, FDA approved tracer, and we have been using it in all kinds of cancers. Breast, lung, lymphoma, thyroid, and it is still being used. But with these newer tracers, they are specific for certain kinds of tumors. Like this one is specific for neuroendocrine tumors, which have not become too aggressive. So this is how it works. This is your radioactive part. This is your protein. And this is your linker. And this is the cell. So this goes and attaches to the cell, goes into the cell, and gives a signal back, and we see where it is. So before this got FDA approved and we were not using it, we were using a different compound which was used for SPECT imaging, which is a different way of imaging. But the sensitivity of that study, that was the best available thing that we had. But the sensitivity was much less than what we have now. So you can see that on the older study, you see this kind of a signal, and on the newer study, how bright it is and how much easier it is to see. So the next step is theranostics. This has been used in nuclear medicine using the radiotracer iodine. How many of you have gotten a thyroid scan done? A thyroid scan for thyroid using iodine? Okay, so this is a scan that we use for thyroid diseases. This has been used for about 75, 80 years. We have been using it. And for treatment of people who are having a hyperfunctioning thyroid gland, or there is increased function, or patients who had thyroid cancer. So we have been imaging it with iodine, which is radioactive, and treating them with radioactive iodine. So the same kind of a philosophy is happening now with other tracers, especially with the first approval of treatment for neuroendocrine tumors, which happened in January of this year by the Food and Drug Administration. This tracers has been used for treatment in Europe for the last 8 to 10 years. We are a little behind on everything, and people were flying out of US, going there to get these treatments. So the theranostics, the simple thing is, it starts with assessment, you diagnose it, therapy, and then the assessment of the patient again. If you can see it, you can treat it. So what happens to the therapy part? So I showed you this gallium that is there. This is the equation, how we image the patient. Now for treatment, what we are doing, we are changing this to a different radioactive substance, which travels very minimally within the body. So this goes in, seeks the tumor cells, and this stays with the tumor, and it only does the radiation of the tumor, and that is how the tumors are treated. So this is one of our clinical trial patients. So you can see the amount of disease. It's all over. And then we treated this patient, and this was the scan immediately after treatment, and you could see the tracer for treatment went into all the areas where you saw all the hotspots. So that is the aim of the treatment. It does it very slowly, and we do 4 treatments 8 weeks apart. That is the protocol right now. And the reason for that is there is radiation to the bone marrow, and we want the bone marrow to come back. We don't want to harm anybody. So recurrent prostate cancer is another thing that has been very, there are radiotracers that are FDA approved and being used for this. So if a patient had a prostate cancer and had definitive therapy, either definitive radiation or if their prostate was removed. So how they are managed is you do the PSA levels on them. And getting the PSA levels, if they are there, because there should be no PSA. So if it is there, then you are concerned about that. So these are the two FDA-approved drugs, radiotracers. And C11 choline was the first tracer that was approved. And Mayo Clinic Rochester had worked on it for years before they got it FDA approved, and they have been using this tracer for almost 5 years. Why other places are not able to do it, there is one reason: you need a cyclotron for this. Because this has a half-life of 20 minutes. So that means whatever you do, in 20 minutes, half of the drug or the agent will be left. Every 20 minutes, it will just keep decaying to half its level. So that is why you have to have an on-site cyclotron so that so usually what we do is, in Rochester, is the patient is on the table. The drug comes from the PET radiochemistry lab, gets injected, so that the patient gets enough dose. And here, you don't see anything on the CT scan, and you see one spot. And that is what is the key to early diagnosis and early treatment. This is the other radiotracer that just got approved in June of 2016. And this is a case where in the prostate bed, you see it being positive. And this is the tracer we are currently using, but we'll be soon using C11 choline once our cyclotron is up and running. Future development, again, is the same thing, same concept that I showed you with neuroendocrine tumors, and that is the goal for prostate cancer, recurrent prostate cancer too. So what we'll be, there is another radiotracer which is particularly for prostate-specific membrane antigen. So it's specific for prostate. So gallium-68, the one that we used for neuroendocrine tumor, will be attached to this molecule and then will be used for diagnosis. And once the diagnosis has happened, then it will be treated with attaching this molecule to the PSMA the same way that we are using it for neuroendocrine tumors. PETMR is a new technology. We just got one installed. It does have its use in brain imaging. It better defines the soft tissues as well as the bone marrow compared to what we see on the CT scans. So a PET data along with the MRI data would be helpful in certain situations. And that is what we are learning from experience, what are the tumors where it will work best. This technology is available at very few places in the country. It has decreased radiation to the patient because this radiation that you get, additional radiation that you get from the CT scan is not there. But these scans take longer. But a lot of times we have patients who get MRI and PET done separately, but now they can be done at the same time in the same scan. So the applications are increasing with research and experience. And brain imaging, pancreatic and liver cancer, GYN malignancies, prostate cancer, multiple myeloma and sarcoma would be some of the indications that we are looking at. We just got it installed in January, and we are going through the training part of it. So this is the difference in the images. This is on the same patient. This is the MR and the corresponding PET image, and this is the CT scan and the corresponding PET image. So in conclusion, I would just like to say that the most important thing is to have early diagnosis for better survival, because once the tumors reach a stage 3 or 4 level, the survival and the treatment becomes difficult, and the survival is much shorter than if we can find them in the early stages, especially stage 1 and 2. Clinical imaging with new biomarkers will personalize medicine. And then screening. I think screening is one thing that we all need to do. Whatever screening tools are available and whatever age limits have been set, I think that is very important to find tumors early so that the next step can be taken. Theranostics for neuroendocrine tumor will be available, and we have clinical patients starting this month, but this will open door for newer agents to come and follow the same path. And then expansion in the PET preclinical research. I would just encourage or ask everybody to and promote molecular imaging, because this is going to impact research, funding, regulatory, and industry involvement. And I think that is the key to find tumors early. So teamwork again, and thank you. Any questions for me?